clinical implications for intraoperative dislocation of the hip necessary for other procedures, I think, are significant. Hips are not made to dislocate, and when a hip dislocates, there is an element of soft tissue damage that is unavoidable. Rather, that's imposed by you as the surgeon or experienced secondarily by the patient just as a consequence of the dislocation. Not having to dislocate the hip intraoperatively, I think, allows, again, for tissue sparing, which plays into the rapid recovery aspect of SuperPath. The more tissue that is spared, including muscles around the hip joint, I think the better the patient is short term, but long term as well, because those muscles continue to function in a normal fashion, and it allows not only for better strength, better range of motion, but better stability due to proprioceptive function of the muscles as well.
Before, when we used the Charnley retractor, which is a type of retractor that pulls the muscles apart, by the end of the case, you take that out and the muscles have tears and it's just traumatizing. Instead, we use techniques that allow you just to very carefully split the muscle fibers apart so you can go through the muscle but not cut anything, and then put in very non-traumatic retaining type of material or retractors that hold it apart. And so at the end of the case, it's a much different situation. The tendons and muscles just fall back together. The only closure really is this capsule, which is something you have to go through, but it's just an incision that you're able to bring back together and suture, which not only adds more stability, but it's more normal and not anatomy. So you're preserving normal anatomy and not traumatizing the tissue.
I do notice a difference in the stability, and I notice it pretty much at time zero. When we're shucking the hip at the conclusion of the procedure, there's very minimal lack of tension because you can grade that fairly easily during the procedure. At the same time, I feel that I can range the patients any way I want and see exactly how how things are gonna go postoperatively. So stability-wise, even though with the anterior muscle sparing approach, the radial dislocation is very low, same thing with the SuperPath. If you have that acetabular position right where you see it should go, patients are not going to dislocate. And that's where I feel most patients have problems, is if the acetabulum is not just in the right position, any change in their alignment is going to make the hip dislocate. What I found with the SuperPath is because we're not dislocating the hip, we're just moving everything out of the way, and we're reaming and broaching with the hip in position, I can follow the patient's natural version, and it gives me a little bit of a hint as to where that cup should go and where the neck of the angle should go to match the patient's anatomy, so that we're not overcorrecting or undercorrecting their prior problems. And that's one thing that I've seen that's very helpful.
Some of the tests that I do intraoperatively to assess stability are rotation. So I'll put the hip in various positions of internal rotation, abduction, and flexion too as well, and address the stability and test the stability at that time. The other test that I'll also use is soft tissue tension. What I've noticed with the SuperPath approach is that I'm able to accurately assess and better assess the soft tissue tension with the SuperPath approach, with the IT band still intact, with all those rotators still intact, and majority of the hip capsule still intact. You have a good understanding of what the hip's tension and stability are with them still in place.
Historically or traditionally, we give posterior dislocation precautions for posterior hips. There are some anterior precautions for anterior hips, and that's a method of containing the hip and sort of helping the hip heal in a manner that is no longer unstable after surgery that requires bigger dissection or even stretching of the soft tissue. Many cases, these precautions are not permanent, but they do impact the patient's lifestyle in a significant fashion, and they may have some minor lifetime restrictions, like avoiding things like deep bends or yoga. And with kind of newer, more alternative techniques, we're able to get the patients back to these type of activities without restriction.
Hip joint stability after super hip approach it's clearly excellent both in surgery and after. We close the hip joint capsule anatomically from the socket rim right down to the shoulder of the prosthesis, which confers great stability to the joint. And of course, we haven't released very much in the process. Most of the short rotators, if not all the short rotators, are intact. And so the hip has excellent range of motion, but also reaches an end range of motion where it does not dislocate. So after surgery, We generally allow patients to put their hip in any position they want to without restriction, and the hip dislocation rate is as low or lower than any other technique that's available. I tend to use relatively small bearings, and the hip dislocation rate is still less than 1 in 700. And I don't think there are any large series of more than 2,000 that have a hip dislocation rate that's lower than that.